Bismillahirrahmanirrahim. Now we are going to look at the last segment of pharmacokinetics, where we are going to look at the excretion. Although we have covered the different topics regarding the intestine, where we have seen in the drug was moving, then the blood vessel, first step was the absorption, then we have discussed the distribution. So we have covered the metabolism. Now we are actually going for this last segment, that is our the excretion. So now, before I go to detail of different terminologies and the explanation for the some term you should be clear: elimination, excretion, and the clearance. So if you are confused with these three terms, so you might be find little bit difficulty in the explanation. So what is elimination? What is excretion? When someone asks, so most of the students say these are same thing, but these are not same thing. These are different. Elimination. Let's look at elimination. Elimination is simply disappearance of active molecule from the site of action, bloodstream, and the body. And what is excretion? Removal of drug outside the body via renal or non-renal route. Okay, let's see what is difference in the elimination and excretion. So in simple term, I define like that. Elimination is actually combination of metabolism and excretion. So in the elimination, we actually want the termination of action. For the termination of action, we should disappear those active molecules from the site of action, from the bloodstream, from the body. So for this purpose, first we metabolize the drug by making it hydrophilic, so because it's easier for the excretion. So second thing, then we go for the excretion. So in the elimination, our concern with the action. So if the action is terminated, means drug is eliminated. But the excretion is what? It's simply removal of drug outside the body, which you can say irreversibly. Okay, we are renal and non-renal. Major organ, because for the excretion is the kidney, other are also important, that are the non-renal route. Okay, hepatic, water, belly, especially saliva, lungs, so these are non-renal. So then, if some drug which have no metabolism, for example, the lithium, which has no metabolism, so in those cases, the elimination should be equal to the excretion. Okay, very straightforward. What is clearance? Clearance is actually volume of plasma completely cleared of the drug per unit time. How much volume of drug you have cleared in the unit time? For example, if you have cleared the 2 liter, where what was the concentration of drug? That doesn't matter. But if you have, for example, 2 liters cleared, where for example you have 100 mg per liter is the concentration. So the amount of if the 2 liters cleared, mean its concentration is 100 mg or 50 mg, doesn't matter. So what is the concentration in that liter has been cleared. So how many hours it takes, so that's important in the clearance. So we come back to all these explanation. So we simply use this formula for the clearance: the rate of elimination of drug and the drug plasma drug concentration, mean how much amount of drug has been cleared out of the kidney and how much drug is remain in your cerebral plasma. So another formula which we use is the clearance is equal to volume of distribution multiplied by the clearance kinetics. So it's dependent on the different factor. Okay, so or we can change like this: this clearance kinetics is clearance over the volume of distribution. Okay. Now the drug elimination rate is the actually amount of drug cleared from the blood per unit time. Now let's look at the excretion, because our job is for the elimination. We have covered the metabolism, so we go for the excretion. So excretion, what is our goal? Our goal is to terminate the action. So for the termination of this section we might let's see. Okay. For the termination of action is from the body to the external environment. So this is a simple definition. So our goal is that. So what is the site where the excretion can occur? Is the majorly is the kidney. So we call them the renal. So we look at the different factors which affect in the renal excretion. What are the other factors which affect which we consider them the non-renal? So like the lungs, your lungs, saliva. So these are different example where you can see they are accurate. We come back to one by one each of them. So first we go for the renal. Okay. So factor number one, which is affecting the physiochemical property of drug, in where we actually look at the two things. Number one is the molecular size. If the molecular size of drug is larger than your pore of your glomerulus of the kidney, so of nephron you can say, so then this drug cannot filter. The second thing is the bending characteristic. If it's bound form, so for example it make the size larger, so they are also not filtered. So their half-life will be longer because they are not filtered. They are it's difficulty for their excretion, so their half-life will be increased. With free drug, which is better for the absorption. Although this concept we have somehow covered in the absorption. So urinary pH, as you know better, if it's a weak acid, opposite medium is weak base. So opposite medium is important for the excretion. So if it's a weak acid, so pH should be basic. Okay, if it's a weak base, then we go for the acidic. Drug interaction, which is important because it's important especially in the excretion where you see the competition for the excretion of different drugs. So we look back later. And the blood flow, because it defines your GFR. So okay, so and the disease setting, if you are the kidney is in the disease condition, renal is dysfunction, means your drug will be remain for the longer period. It's not properly excreted, so we need to think about that. Especially those which are totally dependent upon the renal excretion. Biological factor. So these are what are these factors we cannot change. For example, the facts. This is if you look at the male versus female. In the female, there is 10% lower renal excretion as compared to male. So and if you adult, especially adult, which is 30 to 40%. If in the newborn, this excretion is lower as compared to the adult. So in the clinical part, these two people are very confusing people. One is the baby neonates, other are the pregnant women. Lot of problem coming from for these cases. The other thing is the old age, because in the old age their excretion is slow because of their blood flow and different other problems. So then in those cases their half-life will be longer. So mean the drug remain for longer period. Mean one cause is the duration of action will be increased, but the other fact is it may lead to toxicity. So because the reason is their GFR and impaired tubular function, which is secretion and absorption. Okay, now let's look at this important fact, that is the half-life. Although you are familiar with this stuff, it's a time required to reduce the plasma concentration of 50% of initial concentration. So it's a time actually. Simple. So for example, if you look at if a drug has 50 mg, 500 mg, after for example, its half-life is 2 hours. After the 2 hours, what will happen? It's going to be 250 mg. After the next 2 hours, it's become 125. So after every 2 hours, its concentration is going to half of that. So that is actually half-life. Okay. So elimination is actually of two types. One is the distribution elimination, and the other is half-life is of two types. One is the distribution, other is elimination. Distribution mean when our drug has been absorbed, or other case, for example, in intravenous where is no absorption. So in those cases, after the distribution, if your drug concentration goes, as you absorb, and after the distribution concentration is become 50% of initial concentration, so that is actually a distribution. But the elimination is a different thing, means drug is coming out. So let's look at our concern with the elimination. Okay, so for the how many for example, if you look at the how many half-life are being used for the elimination, after our first half-life, the drug concentration becomes 0%. After 0 time is 0 eliminated. After 1 it's become 50. So after the 2 it's become 75. Okay. So after the next third, 87.5 is excreted. After the fourth, it is 90, because every time it's 50% is going to be excreted after. So if you see, almost 5 half-life has been used for this. So I simply say the student, just remember the rule of 5. Rule of 5 says what? It's 4 to 5 half-life has been needed to eliminate if you are giving no further drug. If you are giving further drug, means it's going to be go for the steady state, which also take 4 to 5 half-life. Okay. So let's look at the half-life, which is actually for the calculation we go for the 0.7. Why we are using 0.7? Because it's actually the log. If you take the logarithm of the 50%, that's going to be 0.693 almost. So that's why roundabout it's 0.7. Okay. So it's elimination half-life. So other formula we can use because K is actually equal to the your clearance over VD. So we also use this formula, K is given. But important thing is the half-life is direct relation, directly related with the your volume of distribution, but it is inversely proportional to the clearance. So why it's important? For example, if the volume of distribution is higher, means your drug is coming out of the blood vessel, it's coming to the main other tissue or in the ICF, interstitial fluid. So it's not available in the plasma. So it's it's not going towards the kidney. So that's why if the volume of distribution is higher, their life half-life will be increased. While if you look at the clearance is opposite. It's if the clearance is increased, their half-life will be shorter. So it's quite element. It's not difficult to understand. So, but the volume of distribution is has no effect over the clearance. Okay. It's sometimes confusion. So factor affecting the elimination. So one is the organ, the other thing which as I mentioned is the one is the filtration, clearance. With for example, plasma protein binding limit the renal filtration, which decrease the clearance. So that's why it's affecting the half-life. And other is the volume of distribution. If it's high, it's coming out of the elimination because this drug is in the tissue, so it cannot be excreted out. Okay, so that's why it's the half-life is the longer. Now, some other fact you might know is they would commonly follow the single dose. But if you look at the single dose, for example, if you have 12 mg you have given after the first half-life, what will be 6, then it's go for 3, then for the 1.5. 0.7, 1.5. Although it's a normal, but we practically we give for the multiple doses. For example, if you have given after first half-life the other dose, so it's become the 18. Okay, so then follow this pattern: 9, 4.5, 2. But after the other half-life, you have given another dose, 21. So 11.5, 5.7. Other half-life you are given 23.5. So 11.1. Although you cannot consider the 12 as a your after the 5 half-life your concentration will be 0.5, because you are giving the multiple doses here and here. So that's why we go for the 11.75. Okay, so we practical, but in the explanation we always discuss the single dose. So but you should know the multiple doses difference. Half-life, one of the important factors over the kinetics. So the first order kinetics, which is confusing for the many students, and the zero order kinetics. First order is simply the constant fraction of the drug that is being eliminated per unit time, and while the zero order is constant amount of drug that is being eliminated per unit time. So just look at the constant fraction is the first, and while the constant amount is in the your zero order. So what does mean fraction? For example, if I mention if some drug has 50%, half of that is going to be eliminated for after 1 hour or 2 hour, 1 hour. So other is I am saying that for example 20 mg is going to be eliminated per unit time. So there are two different things. What is happening? Let's here just look at the example here. For example, constant fraction is 50%, while constant amount is 20 mg. Let's see. We have 100 mg. After 1 hour, what is going to happen? It's going to be 50 mg. After the next 1 hour, it's going to 25. So constant fraction is going to mean 50% of your amount is going to be excreted after each hour. Okay, 12.5, 6.25. If you compare with the, if I say the constant amount is going to be excreted like 100 mg. After 1 hour, what will happen? It's going to be 80 mg. Next hour, 60 mg. Only 20 mg is going to be excreted. After 1 hour, 40 mg, 20 mg. So this pattern is followed. Okay, so you can see if I change the drug, what will happen? For example, if I go for the 160, what will happen? Our concentration will be 80, 50% is going to be excreted. After next hour, 40, 20, 10 mg. So if you look at the here, just you can see the 10 and the 6.5, it's quite relevant. It's not much difference. Okay, if you apply this for the constant amount, for example 160 mg, so what will happen? 1 hour, 140 mg, 120 mg, so like that. So you can see still after at this time we have 80 mg, which is much different from the 20 mg. So you can say in this case, although if you change the concentration, your amount is fixed 20 mg will be exceeded. But if you here in this case, if you change from 100 to 160, what will happen? In this case, it was excreting after 1 hour was the 50. In this case, 80 has been excreted out. So you can say it's concentration dependent, while it's concentration independent. So if you change the concentration, okay, so let's say rate of elimination is directly proportional to plasma concentration, when the rate of elimination is the independent of plasma concentration of drug. Okay, so these conditions can lead to toxicity. For example, alcohol. If someone has taken alcohol for a longer dose, high dose of the alcohol, what will happen? It's may show its action for longer period, because for 2-3 days, because the constant amount is going to be excreted. They follow zero order kinetics. Okay, so just if for the mnemonic I use the FF, first order fraction. Okay, so other thing, if you can note here, is the first order half-life is constant, while the in the zero order it's not constant. Let's see, if here is 180 mg. Okay, here is 160, half of it will be 80. Okay, so how many hours we take? 1, 2, 3, 4. 4 hours we have taken. So in this case, can we say it has 4? No. If you, let's compare with the 120. Here is 120, and if I go for 120, half of it will be the 60. Okay, how many hours it take? 1, 2, 3. So in the last one it was 4, now it's a 3. So you can say its half-life is not constant. Okay. So it's going by in this case after each are 50% is going to be excreted, so their half-life is fixed. But important thing is most of drugs follow the first order kinetic, so we don't confuse with that. But some like alcohol they follow the zero. Here is a mnemonic for the some example which are you must need to know because they are tested. The 0 watt power, it's a mnemonic to the limited drug which follow the warfarin, alcohol and aspirin. A represent 0 watt power, W represent warfarin, A represent alcohol and aspirin, T represent thiophelline, and next T represent butamide, and the P power represent actually phenytoin. So these five, six are follow the zero order kinetics. So, but most of the drug follow the first order. Okay. So if you look at the graphical representation, you can see here it was 1 at this time. After the first half life, it's become 0.5. Then it's become 0.25 and 0.1. If you compare with the in this case in the zero order. I think if it's 30, 40, so it might be a 35, you can say 5 mg is going to be excreted each time here. So what is important thing is that its graph is graph is linear. Okay, it's a linear graph, where it's a non-linear, you can see a curve like structure, so it's a non-linear graph. Okay. Okay, in the first order, it's a non-linear, while in the zero order, it's a. Here we go. Let's see other case, which is what is this? If I ask you, it's a linear. Of course, it's a linear. If I ask you, is a zero order or first order? If you are thinking it's a zero order, I mean you are trapped. Same thing is going to happen in the step 1 exam. So a lot of students trapped because it's a first order. Why it is? It's actually logarithm graph. It's actually extrapolated over the C0 time, where the 800 mg. So if you look at this side, here is mentioned 10 raised to power 2. Mean it's a logarithm graph which is actually differ from the your normal the graph. Okay, in which if you just check your concept, that is in the first order the half life is fixed, and if you look at the here what is happening, if look at the 4 and 2, here is actually 400 and at this point it's a 200. So mean if the half life is here is time is 60 minutes, here is 120, mean your half life is how much? It's a 60. Okay, so it's here is 50% eliminated, so here is a time. So if you compare with the let's see at this point 100, 8 and 4, mean 800 and 400, so mean here is different. So what is the half life? Here to here you can see it's a time is 60. Okay, so it's the same thing. If you compare with the here and here, what is different? Same thing. Here is for example at the 6 and at the 300, 600 and 300. So half life is 30, 90 minus 30 is the still a 60. So it's a half life is fixed. This graph show the half life is fixed. Okay, so that's why it's a first order kinetic. So if you compare in the last time we have, if you here you can check the half life is in the was the 1 hour, and while in this it's not same. Okay, so half life is 1, 2, 3. Okay, so but in this case you can see the same difference is here to here, here to here. So in the logarithm graph is simply you can see, if you look at the spacing between the 2 and 3, it's a much larger. If 3 to 4, 4 to 5, you can see these spacing are going to be closer and closer because it's a logarithm graph. Simply you can see on the y-axis, sometimes it's mentioned the log, sometimes you can see the spacing. If the spacing is closer, becoming closer and closer, means the logarithm graph. So you go for the opposite. Okay, so if your slope is steeper, mean your half-life is shorter. If I say this line which is I think coming right here at 180, if it stop right at the 190 like that, if it's coming like that, mean if it's come here, what will happen? Mean its half-life is shorter. So it's as you go for the steeper slope, so it's a shorter half-life. As the shallow slope like that, that is the longer half, shows the longer half-life. Okay, so just what is important, just clear this concept in the normal graph and the versus. So what is this? Is your logarithm graph. You can see here is I have mentioned the log. So this is normal. So what is this graph? It's for first order. So it's a normal graph for the first order. This is the logarithm graph for the first order. Okay, while here if you look at it, it's opposite. So it's a normal graph which is drug concentration is mentioned, while if you compare with here where you can see it's a curve, so non-linear for the zero. If you confuse with this concept, sometime non-linear, linear as I mentioned, and the other thing half-life was constant, zero linear is linear graph in the normal concentration, while the non-linear in the logarithm. Half-life is not constant as I mentioned. So mnemonic most of the time I don't rely over the mnemonic words. It's helpful somehow. So mnemonic is letter O. Okay, letter O means it's for the graph. If you look at zero, non-linear, log. So in the all world, so zero, the non-linear and the log. So mean in the zero, if it's a log, it's non-linear. If you understand the one, you know the one, you can go for the other easily. Half-life, so not constant. You can see here is 2O, while in the first array it's 1. Just mnemonic. Okay, saturation kinetic is a very important concept, especially in the step 1 exam. Saturation kinetics, so is for example, what does it mean? Drug concentration, normally you see in the first order constant fraction is eliminated, while in the zero order kinetic your constant amount is excreted. Okay, so actually your excretion, the clearance is dependent upon the enzyme, the metabolism and the excretion. So but if the enzyme are limited, what will happen? In the lower dose, what will happen? Your constant portion of drug is going to be eliminated. Okay. While if you give the larger doses, if you give the much doses, higher doses, your constant amount of drug is going to be active because the enzyme saturation occur. So in that those cases we should be careful. Most of the time, if you have the higher dose, so these actually, which for example I have shown the different example zero order, they actually show the zero order kinetics when they go for the higher dose. In the lower dose they show first order, while as they go for the higher dose they show for the zero order because the enzyme saturation. Okay, like that. If you look at the A and B which is mentioned here, so here if you see in this case here is zero order, while as you go in this case it show the first order where the enzyme saturation has been occurred. First order to zero order has been come. Now these are some common example which actually show this case, phenytoin and the thiophyllene. If you see these example in the with the higher dose is mentioned also, a case is presented, so you should be careful regarding this. The volume of distribution is most of we explained it at the zero time. If you see here distribution and metabolism, here actually show the zero order because it's a linear. Fast zero, but in this is a slow zero order kinetics, so because here is metabolism. So in these cases we actually go for the always extrapolate the graph at the concentration at the zero time. So you can see here distribution is faster. So in these cases we simply draw data like that, so we can easily check the concentration at the zero time. So because it's a fast distribution case. So extrapolate like that. Okay, so then you put the concentration. If here you like, for example, if it's, here is 10 mentioned, here is the 8, you can see difference. So always use the concentration at 0 time while you calculating the volume of distribution, and here you can say the amount and dose is mentioned. Now check at the clearance. Clearance, as I mentioned, volume of plasma cleared per unit rate of elimination of drug and the plasma drug concentration. Simply look at it. So clearance is actually renal, and clearance always, and other non-renal is also included when you see the total body clearance. Okay, let's see. For example, here to here. So if you look at here, you can see the amount has been plasma drug has come in from the plasma and enter into the kidney. So then it's eliminated. So we check out how my drug is remain still in the plasma and how my drug has been eliminated out of the kidney. So that's why the rate of elimination of drug, how much drug has been eliminated. Other is what is the concentration of drug which is still in the plasma. So we check out the clearance like that. So if you have cardiac problem or hepatic or renal, if a cardiac problem means your blood flow is coming less. If it is a hepatic problem, metabolism is affected. Renal dysfunction mean then excretion will be affected. So all these factors affect the clearance. So which go for the adverse effect mean your drug is still in the body, so it can cause the adverse effect. So if a plasma drug concentration, we cannot do anything. What is rate of elimination of drug is dependent on the GFR and the glomerular filtration rate and the active secretion minus the reabsorption. So these are actually factors because the GF filtration and the secretion is go for the excretion, while the reabsorption is mean it's coming back to the body. So those drugs which you know better, normally GFR is 125 ml per minute or 120. So how we check the patient GFR? By simply given the inulin or creatinine, because they have no secretion and reabsorption. So that's why the active secretion is 0, mean reabsorption is 0. So GFR will be equal to elimination. So mean we can simply calculate like that the elimination of this inulin or the creatinine. So we can check out the GFR. You know better in the physiology if you have an idea. So let's before we go to the rate of elimination, so just recall your mind. I'm not going to explain all this because we have covered in the absorption, but some concept you must recall your mind. So number one is the what are the factors for the elimination? Medium should be opposite. Okay, for the drug, if weak, it should be acidic. If it is a weak acid, the medium should be basic. And the other thing is the ionized form and the hydrophilic. So these are components which help for the hydrophilic, which we have achieved by the metabolism. Okay. So other thing you must need to know, although you know unionized is going to absorb, ionized go for the elimination. So what is important thing is the term, the protonated and unprotonated. I have noticed many of students still confuse the protonated unprotonated. Simply, if it's an acidic medium, mean your drug should be always protonated form. Whether it's acidic or basic doesn't matter. Because why? Because you know they have power to donate the hydrogen ion. So that's why they donate the hydrogen ion, mean they are protonated. So if it's acidic, if you have seen the drug is in an acidic medium, if it would be a base, that's opposite medium for the base. So protonated form of the you can say the basic medium mean a weak base drug is better for the excretion, while the unprotonated form of the weak acid is better for the elimination. Other thing, if you see here, protonated in the weak base, it's a cation. You can see the positive ion is here, cation T is look like positive, and here is the anion. So it's for the elimination. So we'll go for the So important thing, non-ionized and ionized. Non-ionized form go for the active secretion as well as the reabsorb, but the ionized form, they are trapped, so they are filtered. So although we have covered the, I think, acidic and basic drug poisoning. So simple, if it's a poisoning, go for the change the simply pH of urine, so you can get. So I'm not going to explain because we have covered the in the absorption already. Okay, so let's look at the rate of elimination, which is dependent upon the GFR, the glomerular filtration rate. So first look at this. This first arrow. What are the factors which are what type of drug which can enter into the your glomerulus? Okay, so filtered and non-filtered drug. So I recommend just understand what type of drug that are not going to be filtered. The number one is if it's bound with the plasma protein, if it's molecular size is more than larger, for example, more than 20,000, you can say. So it cannot cross the pores of glomerulus, so it cannot come into the filter. But if you are thinking the all other kind, for example, if it's a free drug, it's ionized or the smaller molecular size, non-ionized, whatever, hydrophilic, lipo, all drug can be filtered here, so they can enter into the your the tubular system. Okay, so but if you this actually defines your GFR. So if only free drug is coming, so let's look at it later. Free drug, all if it's a bound, it's not. So that's why we sometimes calculate the clearance like that. Free drug multiplied by the GFR, so it's a calculation for the clearance. So because only free drug come out of the excretion method. So other thing, the second step is our the active secretion. So active secretion, so your anion and cation, different anion and cation are going to be secreted, mean they are going to enter into the tubular system, so coming out of the plasma, or you can say blood vessel, so enter. So as I mentioned, what is important anion, which as mentioned, unprotonated drug, weak acid drug, so they are anion, while the protonated form of the weak bases, they are the cation, so they can come into the renal tubule. Okay, but as I mentioned, the premature infants and neonates, they are complicated people. So they incompletely develop the tubular system secretory mechanism. So that's why their drug retained in the blood mean they are not going to properly secreted in the renal tubule. So they are complicated people. The other thing, this is low specificity. If this means it's if it's anion and cation, it's good, that's going to be secreted. But there is competition for the different anion and different cation. So one of the important fact that is the for example, a patient come into clinic. Okay, so not in clinic, he is what he has done already. He was the arthritis patient. So he's in the minutes, he has a joint pain. For the pain relief, analgesia, he take the aspirin. What his severely pain has been increased. What is mechanism? Actually, your aspirin and uric acid compete for the excretion in the actually at the secretion point. So they compete. If the aspirin is present, means your uric acid is going back to your blood. As they go back to the blood, they go to the joints, they are going to increase the pain, because they are going to be deposited in your joints. If it's too much, it can lead to gout. So instead of taking his pain relief drug, he has done what he has done. He has increased the pain because of this mistake. Okay, so there is competition for different drugs. So for example, aspirin and uric acid. So we should be careful regarding different conditions. Okay, the next stage is the reabsorption. Although it's a physiology part, so I am explaining what here. So the unionized and lipophilic, if it's unionized and lipophilic, as I mentioned, they are best for the absorption, so they go back, crossing the membrane, they go back in the distal tubule. So what is, that's why if I mentioned here, so this arrow was entering go for the excretion, this secretion. So these two here, these arrows are actually going for the excretion, so that's why I have added them, while this the unionized lipophilic has gone back. Okay, so if you look at this filtered list, free drug, smaller molecule, hydrophilic, ionized, they are going for the excretion, while this non-ionized and lipophilic, these last two member has been come back to the blood, so they still remain in the blood until they are becoming ionized and the hydrophilic. So only the ionized form and hydrophilic can be excreted. So this is regarding the all about the renal. Now let's look at the non-renal excretion. So non-renal, especially one is important with the battery route. Some drug and their metabolite actively excreted into the bile. So for example, the ampicillin and rifampicillin, so they use the battery route. So some drug undergo the enterohepatic circulation. So oral, for example, oral control. What is the enterohepatic circulation? Entero mean hepatic mean liver. Entero means your gastric tract. So GAT. When enterohepatic means your drug is circulated from liver to intestine, intestine to liver, liver to intestine. So if you look at here, so means your drug is coming from first it has been absorbed and go to the liver. First metabolized. After this, what is happened? This drug has come out of the battery route and to the again come back to the duodenum part, or you can say. So again, what is happened here? So here it was by the liver has been conjugated by the metabolism. Now by the your gut flora, or you can say the normal bacteria which is living in the kidney, so they unconjugate. As they unconjugate, means it's again available for the absorption. So they go back and again, so they remain for the longer period. So that's why oral contraceptive have the somehow longer half-life. Okay, so this was some major route. If you look at some other route like saliva, which some drug like phenytoin is excreted by that. The sweat is also route of excretion. For example, the salicylate. So and lungs, you know better for the for example, gas, anesthetic. So and if someone has taken that abuse, I mean alcohol, I am saying. So if someone has taken the alcohol, so they can be smelled out, because the one of route of the excretion for the alcohol is also lung. Gas anesthetic is a good example. So breast milk. So by the breast milk, so mean it can go to the baby. So for example, amiodarone, aspirin. So we should be careful. As I mentioned, so the pregnant women are the very complicated people, and if are pregnant and the lactating, so they should be careful regarding that taking different drug. Neonates, pregnant, lactating. Oh, people. So if you look at the non-renal, so if the non-renal battery, especially battery do what mean if some drug is also excreted by the battery, it mean they are going to increase the excretion rate. So that's why in those cases we see the graph like this. It's also checked in the your step 1 exam. Normally it's like that, while if you see here, its excretion is increased, so they come down. The because show the excretion is increased, so it's especially in the battery root system. Okay, so as I mentioned, if the liver first biotransform the your drug, and what will happen? They come by the battery route, by the sphincter of Oddi, come into the your lumen, and then they gut bacteria unconjugate, and they go back and again. So this is hepatic. So just like that. So GAT to the liver to the your belly secretion to the sphincter of Oddi. So this is your enterohepatic circulation. Okay. So if you look at the what will happen for the enterohepatic circulation, mean their half-life, mean their duration of action is going to be increased. So your graphical representation in the step 1 exam are checked like that. So it's a normal graph, but enterohepatic graph will be like that, because it shows what if you look at the duration of action. For example, it's a normal. Okay, it's a normal is here, while by the entire hepatic circulation, your duration of action has been increased. Okay, so now this pharmacodynamics is our next topic. So thank you. Our lecture is over for the pharmacokinetics. Thank you very much, Allah Hafiz.